Thanks for everybody joining today. We have another fantastic ROVER panel. Today, the topic's upper GI malignancies, and we're going to go through 3 cases. So I will hand it over to our resident moderator, Juliana, to introduce our speakers.
Thank you. Thank you all for being here. Today we have 3 fantastic expert panelists. They'll be presenting cases on pancreatic cancer, hepatocellular carcinoma, and esophageal cancer. We have Dr. Michael Buckstein from Mount Sinai in New York, Dr. Nina Sanford from UT Southwestern, and Dr. Krishan Jethwa from Mayo Clinic. So our first presenter will be Dr. Buckstein. I'll start with case 1.
Great. Thank you so much. Thank you so much to the organizers for letting me join. This is a great opportunity. I'm a big fan of what ROVER does and also ACRO and everything like that. And so it's a great opportunity to discuss these things. I have to apologize in advance. I have another place to run to, so I'm going to have to sign off. But I'm really disappointed because I wanted to hear what Dr. Jethwa and Dr. Sanford had to say, because these are 2 experts in radiation in the GI world. So I'm sorry to miss it, but I'll do the best I can. And so I'll start out with here a case of pancreatic cancer. So we have a 60-year-old female who was presented. She has a history, past medical history, which is irrelevant largely, other than having diabetes, non-insulin dependent diabetes. And it was well controlled until about 3 months prior to presentation, where she started to have strangely elevated blood glucose, and it wasn't controlled. She had been on metformin for years and never had a problem. And all of a sudden now her blood glucose was uncontrollable as well. Also developed subsequently abdominal pain and had about 22 pounds of weight loss over the course of about 2 months or so. Her pain was epigastric in origin, radiating to her back. It was about 9 out of 10 in its worst intensity, and she was very hesitant to take anything stronger than Tylenol, but had adequate pain relief with that alone. On questioning, she also endorsed that she had recent sort of bloating, a lot of gas, early satiety, just wasn't feeling well in the GI space as well. And of note as well, she also denied any recent jaundice, any pruritus, anything else like that. On physical exam, she was a normal-looking female. She had no scleral icterus or any sign of jaundice in her anywhere else. And her abdomen overall was soft and non-tender. Even in the epigastric region, you could not elicit pain with palpation. On laboratory findings, she had a resting blood glucose anywhere from 140 to 350 going through her notes from her primary doctors and like that, where she was running. Her hemoglobin A1C, which had been watched carefully because she was a diabetic, had been normal in really the 5 to 6 range, and all of a sudden had jumped to 11.3 over the course of about 3 or 4 months as well. And her T-Billy was 0.4. Her CA 19.9 was when normal, 24.7. The CA was elevated at 11.4. And the patient was then subsequently referred for a CT scan. So you can see that her CT scan, this is an axial CT scan with IV contrast. And you're looking at the mid-abdominal region. This is something that you'll see as radiation oncology residents, or if you're those who are residents or medical students, you have to know this anatomy very well, this intricate relationship here. But you're looking at the pancreas, and it's tough in a single slice. This is a duodenum, this is the pancreatic head. And take my word for it, there's something abnormal sitting here we call the pancreatic neck. And when you look at pancreatic cancer, the first thing is looking at what we're potentially seeing here. And then secondly, the relationship of the anatomical structures around that area. And so we look at here is SMV and SMA, and you can see that the tumor appears to be very, very closely associated with those 2 blood vessels on this particular slice. Just bringing to note. Thank you, Juliana, for showing that. So this was her CT scan that she got. Otherwise, her CT scan did not show any abnormalities in the liver and did not show any abnormalities in the lungs as well. And so our first question for the group here is what is the best way to make a diagnosis for this patient? CT guided biopsy, ERCP, surgical resection, right? Go just take them to the OR and remove it, or a ctDNA guided biopsy. Okay, great. So we're seeing, looks like the majority recommend ERCP, as well as the rest of you recommended a CT-guided biopsy. These patients typically get their biopsies done through ERCP. That tends to be the most direct route. I tried to pick a case of pancreatic cancer that wasn't the standard case, which is painless jaundice, at which point those patients get an ERCP because the ERCP not only makes a diagnosis on biopsy, but also allows them to put a stent to relieve the jaundice. And so so typically these patients will have an endoscopic approach for getting the biopsy done. It also potentially is less invasive in terms of, needles and seeding and things like that as well. So this patient was confirmed, next slide please, to have pancreatic adenocarcinoma. And the next question for the group is, what is the next best step in management? We're radiation oncologists, we can jump right into a good course of SBRT. We can do a surgical exploration and to at least remove it or maximally debulk the tumor. Go right into chemotherapy, or we could make a palliative care consult and say, this patient has pancreatic cancer. We know this is not a good one. Should we just throw in the towel now? Okay, great. So we're seeing, again, the majority looks recommending chemotherapy as a starting regimen. And then the rest say that we should do a surgical exploration and resection. I think these are really, really good choices. I mean, no one went right for the SBRT, despite this being a ROVER platform, which is good. This patient actually got chemotherapy to start. It's hard to tell, given I had very limited slides to show you that any patient with pancreatic cancer who has any sort of vessel involvement, those patients, by definition, usually they might get an exploration just to do a staging laparoscopy, depending on the institutional preferences and the level of suspicion for carcinomatosis. But most patients, will start out with chemotherapy, and there are really two active regimens. We use what's called FOLFIRINOX or we use Gemabraxane, which is another regimen. And those are the two things that we do. Even patients, I think at my institution and probably most institutions, resected tomorrow, the patient could be in the OR the next day. Those patients tend to get at least a trial of chemotherapy prior to consideration for surgical resection because of the ominous nature of pancreatic cancer, because we tend to sort of give it a trial run of that. The data supporting that is a tough platform and limited time to discuss that. Isn't necessarily the most robust data, but there certainly is a signal that most institutions tend to start out with a trial of chemotherapy to start. And this patient received FOLFIRINOX. She tolerated the chemotherapy very well. She managed to have an improvement in her epigastric pain. She had relatively minimal neuropathy from the chemotherapy, did well. And then she gets her first scan, which is a little bit smaller to see here. So just looking at this scan, you can see that perhaps if you squint or use your imagination, the mass in the primary mass itself is maybe a little bit smaller, but certainly not much smaller. She appeared to have a relatively minimal response. I mentioned before that her CA 19.9 was not elevated. The CA dropped to about 8, so it didn't go down very, very much. The liver remained free of disease at this time, but we would consider this to be a very, very suboptimal response to systemic therapy as well. And so at that point, the discussion was made, to whether we should then change her systemic therapy to a secondary option, a different regimen, the second regimen being Gemabraxane or some other thing or a clinical trial, versus considering sort of local regional therapy. The patient remained unresectable because of the fact that she had vessel involvement. And so the decision was made in our institution to proceed with SBRT, which is what we offered for her as a definitive therapy for local regional control. Next slide. So this patient was treated with SBRT. We simulated her with alpha cradle with a breath hold technique. So we had her hold her breath during treatment using gating through various structures. And sometimes we put in fiducial markers. This patient was very reluctant to have a secondary procedure with ERCP, so we had to use other methods to help use her breath hold. We treated with 40 gray in 5 fractions, which is I think becoming somewhat of a standard dose in terms of how we manage SBRT. Some people are pushing a little bit more into the 50 gray range. The old-fashioned dose range previously was around 30 gray in 5 fractions, or 33 gray in 5 fractions as well. And we used a very conservative constraint that the only real consideration for her was meeting the duodenal constraint. And here we use something which is even more conservative than most used, which is 30 gray to 0.3 cc's of duodenum. And as I mentioned before, this was a pancreatic neck lesion. So it really wasn't even in the head. And so it actually was very easy to meet her dose constraints in this particular case. This was a LINAC-based treatment in terms of how we deliver the radiation. And she tolerated it very, very well and did great. So I think it's now time to sort of open up to discussion about aspects of this case that kind of go into it. So I don't know, Juliana, whether we open up to discussion or for questions, or I should just kind of pose the issues. How do you want to do this?
Yeah, everyone is welcome to ask questions by typing in the chat. If you just direct your questions to everyone, we can see them and read them to Dr. Buckstein.
And I can certainly start out. So I listed a few things. Pancreatic cancer actually is, I'm a GI radiation oncologist, and I have to admit, it's hard to know where radiation fits into the overall picture of pancreatic cancer. It's very, very complicated because it's a complicated disease that has to be sort of nuanced accordingly. And so I think these are some of the issues that I came up with as well. If nobody else has, I don't know if any questions came in already. If you have any, let me know. I can just start discussing things, and certainly if any one of other discussants, panelists wanted to chime in as well. There are a few, controversies or so. This is a great question. Yeah. So someone asked a question about what about doing SBRT for borderline resectable disease? So this is what I think a lot of us are doing. That the role for radiation typically is for unresectable disease and borderline resectable. The borderline resectable seemed like the obvious place to go for patients that could potentially go to surgery, because we are radoncs. We do think that there's some local control to be gained by adding SBRT. It fits in very, very nicely after having a trial of chemotherapy prior to surgery to kind of go in and do that. We have plenty of data that it is safe, that it seems to be okay to do. The biggest kind of wrench that happened was that this was attempted in a trial by Alliance, one of the big cooperative groups, and that was just for reasons that we don't fully understand, was an ill-fated trial and did not show any benefit to using SBRT per se. But it also even showed a strangely more positive margins, which again is a little bit of we think is just kind of bad luck for whatever reason. So I can say at my institution, we actually do incorporate it selectively in cases where we feel like it's going to be a tough resection. They're going to be working really, really hard around the vasculature, and that might sort of sterilize things around the vasculature or the retroperitoneal margin to help get some control. That's where we use it typically. I think Dr. Sanford had something to say as well.
I just typing my comments in the chat box, but yeah, I completely agree with what you summarized. For borderline, we tend to start with chemotherapy, which is what the NCCN guidelines suggest, and then restage with a repeat tumor markers and imaging studies, reassess resectability. And generally, and for if there's continued arterial involvement, we do recommend pre-op radiation. We tend to try to do that with SBRT, whereas venous involvement, which the surgeons are a little bit more comfortable reconstructing and operating on, sometimes they'll go straight to surgery. And I also just put in the chat, Dr. Buckstein, you mentioned the Alliance borderline trial. I don't think we need to get into all the nuances of the study, but Bill Hall had a really good comment that was published in JAMA talking about some of the nuances of that trial that I think would be important to read. Because you do hear people say people who receive radiation are dying, and radiation is shortening their lifespan, which doesn't make sense at face value. And I think it's important to be able to push back on that.
Absolutely. I think anyone in the radonc world knows, we're usually everyone pushes against. So we have to always know the data and know the defense of the data so that we can understand and know where we fit in that particular place. Sorry, I missed the.
I have someone also asked, so do some institutions favor neoadjuvant for resectable disease? So we do not do that. Like Dr. Buckstein mentioned, practice patterns vary greatly. Where I did residency, almost every patient with pancreas cancer got radiation. That was at MGH. And I think Medical College of Wisconsin does that as well. But generally for resectable, I think there is equipoise between starting with neoadjuvant chemotherapy or going straight to surgery. I think most academic centers are starting with chemotherapy, but there is a currently enrolling Alliance trial comparing upfront surgery versus perioperative chemotherapy that will address those two regimens. And that trial does not have radiation. Now, RTOG 0848, which looked at post-op radiation, was just presented, has not been published, and that showed a benefit in the node negative setting that was given adjuvantly. That was using just gemcitabine, so also like sort of an outdated chemotherapy regimen, but I think that has reopened the question of the role of radiation for resectable tumors, and hopefully will be an impetus for more studies in that setting.
Absolutely, yeah. Again, we don't routinely, any patient that can go to the OR, we do not offer radiation for, and for that reason alone. But again, it very much varies from institution to institution. Another important thing, just to I mean, we're time is running out here, but it's one question is that it's a little bit one of these controversies in the radonc world in terms of managing, let's say, unresectable pancreatic cancer. Are you an SBRP person or are you a hypofrac person? And I'm curious to hear what our panelists do as well, because the SBRT, you can achieve doses, but people have argued that at least the historical doses used in SBRT trials to date have not been ablative doses, and that what we really need to get this disease under control is more ablative doses, which means that you have to go back to first principles of radiation, which is fractionation, and then hypofractionation, and eventually dose escalation. And so that also varies institution by institution, and again, the data is really out there. This will hopefully be studied prospectively soon. At least we're going to get some signal of that from NRG. But it's one of those questions which is coming up now: is which camp do you fall into, or which one do you want to, and how much do you believe that radiation can really help these patients and push the needle for this very challenging disease? Yeah, so this one, so every pancreatic cancer case, well, not everyone, but most of them end unhappily. So this patient, we went ahead and treated her. She did great. She tolerated SBRT, felt good. We had control for about 3 months, and then you get your next set of scans, and the patient has liver metastases, as to be expected. Now, the left side, you can see that's her liver metastases, and this is a very typical picture for what happens to these patients, unfortunately. On the right side, you can see that, again, you can use your imagination, but trust me, that there was control in pancreatic head and pancreatic mass. So radiation does offer local control, and it does that. I think one of the beauties of SBRT is it offers local control without a lot of morbidity, without a lot of time for the patient, and they can go back on their systemic therapy as opposed to putting through the classic, let's say, 25 fractions with concurrent capecitabine, which is a very different treatment choice. And so I think it very much falls into that window of what we consider acceptable in terms of what we do for these patients. But it's very, very challenging as well. But you'll see a lot of cases. I think I have 2 minutes left in my session. I mean, things that are coming up as well is like MR-Linac versus not. So I know those who have the luxury of an MR-Linac, we're getting one put in. I think you have one, Nina. You guys have an MR-Linac, or Mayo does, right? You guys have an MR, probably.
We have Ethos, CT-based adaptive.
So people are arguing, again, to get higher doses, and the upper GI world, this is one of the most, I would say, challenging spaces in the radonc world to get ablative doses, because you have a lot of moving structures that are distensible with luminal organs. And so it's one of those places where either using an MR-based Linac or Ethos or these new platforms, or any kind of image guidance really makes a huge difference. And where adaptive radiation, again, might help us push the envelope a little bit. But ultimately, I chose this case partially because it didn't have a classic presentation, but partially because I think it's sobering that we are radoncs. We have a lot to offer these patients, but ultimately these patients, it's a systemic disease. Until we get a really good way of controlling this disease completely systemically, then the benefit of local therapy still remains in question.
Dr. Buckstein, thank you very much for the excellent.
Thank you so much. I really appreciate it. Again, I apologize for having to run out. I really want to hear the other two speakers, but I'll get it next time.
Thank you. It's now my pleasure to introduce Dr. Sanford for our next case.
Sure. So I'm going to be talking about HCC, and I think a little bit different than the other cases. I just wanted to start off with like 4 slides of HCC management, like a 20,000-foot overview, because for the longest time, I really felt like HCC was a whole black box. You know, you have surgery, transplant, systemic, all the local regional therapies. So I'm just going to go over these slides quickly. We can send them out if you want them for reference, and then we'll get into the case. So when we talk about how to diagnose HCC, it's a unique tumor in that you actually, pathology is not required. Imaging, it's diagnosed based on imaging, MR or CT. We use MR here. Biomarkers itself are insufficient, though can be suggestive, and about 40% of HCC actually have a normal AFP. The imaging criteria is based on LIRADS, and within LIRADS, AFI or non-rim AFI, which means the whole tumor is bright, not just the rim, the outside border, and delayed washout are the strongest features. Of the criteria, threshold growth is actually the least predictive. And as you can see by the table, tumor size is taken into consideration because imaging accuracy is less for smaller tumors. And I just put on the right from LR3 to 5 and the other outcomes, the likelihood that the tumor is HCC and the general management options. Next slide. So this is the Barcelona liver system. It is, I think, the most widely used. However, I really think it is better for prognostication than really treatment algorithms, but it is quite widely used. You'll see there are some things that are outdated with it, TACE, TARE, and also radiation is not there. But I think it's still really important to know because this is what you'll hear a lot in terms of how patients are staged. Next slide. Okay, so let's just start with early stage, and that includes very early stage and early stage. So for these patients, there are essentially 3 routes they can go, and we'll go through each of them individually. The first is resection, surgery. This is considered the treatment of choice for patients with either one tumor or without underlying cirrhosis. It's also considered if they have cirrhosis but don't have so-called clinically significant portal hypertension or decompensation. And generally, clinically significant portal hypertension we see in patients with platelets of less than 100 K, and decompensation if they have ascites or encephalopathy. There's actually no restriction on the tumor size for resection as long as the predicted functional liver remnant is sufficient. There is some data for resection if you have greater than 1 tumor, but these livers are thought to really have more of a field cancerization issue. Thus, they may need more than local therapy. So that's resection. And then transplant, this is a treatment of choice for patients who have decompensated cirrhosis or more than 1 tumor. However, the tumor must be more than 2 centimeters to qualify for exception points. And I have another slide on transplant. And then other local therapies, ablation, SBRT, TARE. This is, at this point, reserved for patients who are not candidates for resection or transplant. However, if a tumor is less than 2 centimeters and they are a transplant candidate, one might consider waiting so they can progress to transplant eligibility. Next slide. All right, so just very briefly on all the other stages. So stage B, we consider intermediate stage. These are patients who have liver-confined disease above early stage but are not resection candidates. There are really 3 routes these patients can go. One is downstaging to get to transplant. On the other end is systemic therapy, if this is generally considered for bilobar or extensive disease burden. And the third is the so-called destination local therapy, where the end treatment is a local therapy. Again, this is a very heterogeneous group. There are studies coming up on the role of combination therapies. This is really a difficult population to just say one treatment option because it's very heterogeneous. Stage C, we have advanced systemic therapy is the treatment of choice for these patients. And then stage D, these are really patients with very limited or short predicted lifespan, and they go down the best supportive care route. Systemic therapy 101, this is obviously very basic. First line is atezo-bev or durva-tremi. We tend to choose the STRIDE regimen, durva-tremi, in patients with high risk of GI bleed. If they cannot receive immunotherapy, we tend to give these patients Lenvima. And then second line is often Lenvima or Ipi-Nivo after atezo-bev. And there are actually upcoming studies with new immunotherapy-based regimens. Next slide. Okay. One slide on transplant. I know this is a lot of text, but I'll go through it because I think it's important to understand how transplant fits into things because it is a different option that is not present in other GI cancers. So why is transplant good? So transplant removes both the gross tumor and fixes the underlying liver dysfunction. However, it's obviously an involved process and there is limited organ availability. Prioritization is based upon the MELD sodium score. The components are here and is given to the sickest patients. However, patients with HCC can receive exception points. Why do we use exception points? It's because the MELD score does not adequately capture the risk of death in patients with cancer. So it's going to underestimate their risk of death, so they're not going to get bumped to receive transplant. For a patient with HCC to qualify for exception points, they need to meet the Milan criteria listed below and also get through a 6-month wait period without progressing out of eligibility. And then this is a technicality, but the number of exception points you get depends on where you live. And it's generally 3 less than the median MELD that patients receive transplant for in your geographic region. So that leads us to how do we get a patient to transplant? So there are really 2 concepts here. One is bridging therapy. So this is a patient who already meets criteria. You give them a local therapy to reduce the risk of waitlist dropout. And then the other is that they meet this downstaging at initial diagnosis. So it's not huge, but just a little bit bigger than Milan criteria. And then you give them a local therapy to get into Milan criteria. Okay. So that's a lot of information, but I just wanted to put that in the background. You notice that I didn't even talk about radiation here because I think it's really important as rad oncs to really understand the big picture to be able to advocate for our modality. All right, now getting into the case. Okay, so this is actually a patient that I treated recently, but he, when I first met him, he's a 76-year-old guy. He was found to have alcohol-related cirrhosis, diagnosed in 2017 when he had a cholecystectomy. And then nothing happened for 6 years, but then he developed abdominal pain, had an MRI performed, and that showed a 2.7-meter tumor in the right liver, LR5. They attempted TACE, but this was aborted because the angiogram did not successfully visualize the lesion. So they did a repeat MRI, which I'll show, and then for the purposes of considering treatment options, he had great performance status with an ECOG performance status of 0. Next slide. Okay, so this was the MRI. So I'm just going to go over what we see here. So the not the red arrow, but the lighter arrow in the corner is pointing to the tumor. So it's about a 2.6 centimeter tumor. It's categorized as LR5 because there's non-rim enhancement. Again, the whole thing is bright, not just the edge. If just the edge is right, that sometimes suggests a different pathology such as cholangiocarcinoma. But the whole thing is bright, and I didn't show here, but it has delayed washout on later sequences. You also see signs of portal hypertension with splenomegaly. You can see ascites, though not on the sequence, and then that red arrow is actually pointing to portal vein thrombus. His labs are here along with the normal range, so you always want to know the bilirubin, the INR, and the albumin, encephalopathies and ascites to calculate the Child-Pugh score. You want to know the tumor marker, the AFP, and then also the platelets to look at the degree of portal hypertension and to see whether or not he's a surgical candidate. Okay, first question. What is the patient's Child-Pugh score? Perfect. Yes. So it's A6. So you can go to the next slide. And it's just because the albumin is a touch low. So it's important to obviously calculate Child-Pugh score, but also know what's driving that because it is different if the patient has encephalopathy or ascites versus an albumin that's 0.1 out of range. So it's important to know what features are driving that. Next slide. Okay, so just to summarize, we have a ECOG performance status 0 patient. He has unifocal HCC. It's BCLC-A, early stage. Next slide. All right. What are your treatment recommendations? Okay, great. So this is a little bit of a trick question. So I'm glad we had different people choose different things. So because his platelets are less than 100K, it does make him a high-risk surgical candidate. Because it's a morbid procedure in a patient with thrombocytopenia. So generally, surgery is contraindicated in those patients. We have to remember that TACE, he was actually unable to receive because of the arterial supply of the tumor. Taro had been fine. The patient said he preferred a non-invasive treatment. So the two options really here are transplant or SBRT. And you'll see that we end up using SBRT as the potential bridge. But remember, for transplant, he does meet the Milan criteria, but we need to wait to get those MELD exception points. He doesn't quite reach that threshold yet. Next slide. Okay, so I think someone asked earlier, so we do tend to treat these patients on our MR adaptive radiation. This wasn't like the best sequence, but the white circle shows the tumor. And then the picture below obviously shows the dose distribution. We treated in 48 gray in 3 fractions. We right now don't have ABC on Unity, so we treat them with compression. But he did really well with treatment. This is what we think of as a favorable location for SBRT. It's not really near the luminal structures, the stomach. So he did well with SBRT. Next slide. Okay, so he completed SBRT a couple of months ago, or I should say about half a year ago. And the most recent MR is here. You can see that there is no focal enhancement in the area of the tumor, like you don't see any, circumscribed tumor, but there is geographic brightness. The whole region is a little bit bright, and that is consistent with post-radiation change. And this is graded as LRTR non-viable. So just after 2004, there is a new grading system after SBRT and Y90. So there is viable, which is, the worst, obviously, it's viable and progressing. There's non-progressing, which is essentially that it's not getting bigger, but there may still be live tumor cells. You may have to wait. And then there's non-viable, which is the best category. This is graded as non-viable. So he is currently awaiting transplant. His current MELD is 11, but his liver function is actually continuing to decline. So he's on the transplant list, and hopefully that will happen for him. And that is it. Thank you. Happy to take any questions or talk about anything.
Thank you, Dr. Sanford. That was excellent. If anyone has any questions, feel free to type them in the chat. I have one here.
Do you consider lorazepam to improve motion management? That is a great question. So I think, I think for patients who have claustrophobia, especially in the MRI, we do give them benzos before. And yeah, it's really to get them through the scan. And I suppose it would improve motion management as well. Without an MR Atlantic, how would you change your treatment for fractionation? Yeah, so before we had our Unity, the fractionation was actually the same, which is 48 and 3 for better functioning livers, and then 40 and 5 for a child PUB. I think, yeah, so the dose fractionation would be the same. I think we would just probably be a little bit more shy with regards to needing to de-escalate the dose and underdose at interfaces with OARs. Do you ever proceed without fiducials? So yes, now we do. So because we can see them pretty well on the Unity, we don't use fiducials anymore. We were using them when before we started treating on the MR. Okay, since HCC can be radiosensitive, and if you know yours, yes, I think that's a really good question. So yeah, this is something that you'll hear at Tumor Board. You'll hear IR saying, Well, with Y90, we can get like 300 gray to the tumor. Like, of course, that is a better treatment than SBRT. Like, we're literally getting 10 times more dose. First of all, a caveat of that is that's not to the whole tumor. That's really just to a part of the tumor. And the second, sometimes I say that HCC is radiosensitive. We probably don't need that high dose, and there are trade-offs with that. So yeah, I totally agree here, especially if a patient is bridging to transplant and the tumor is larger, then you probably don't need to ablate it completely, especially if there's a risk of liver decompensation. So I think that is a case where it may be reasonable to lower the dose or at least dose reduce in your OARs.
Wonderful. Thank you very much, Dr. Sanford. I'd now like to introduce Dr. Jethwa.
Great, thanks for the introduction and invitation to be here. So I'm going to be talking about esophagus cancer, and I have a tough act to follow with Dr. Sanford and Buckstein prior. But for initial presentation, this is an 84-year-old male with a past medical history significant for GERD, coronary artery disease, hypertension, and a AAA status post-endovascular repair. He also has a history of, I would say, moderately severe Parkinson's disease. He presented with a 6-month history of progressively worsening solid food dysphagia and 30 pounds unintentional weight loss. Labs were most notable for a CBC and CMP that were unremarkable, but the patient was recommended to proceed with an EGD, which demonstrated an ulcerative fungating circumferential mass in the lower third of the esophagus, extending from 34 to 41 centimeters from the incisors. The GE junction was at 39 centimeters. Biopsy was obtained, and it showed moderately differentiated adenocarcinoma, MMR proficient. So this was followed by staging studies. The CT chest, ab, and pelvis is shown here. This is a study with intravenous contrast, and I'm showing you axial slices. Juliana, if you're able to click the play button, this will be a video. And you'll be able to see here that there's thickening of the esophagus wall. The esophagus wall mucosa tends to contrast enhance. Masses tend to be relatively less contrast enhancing, so that hypodense appearing mass inside the esophagus with the associated wall thickening is the esophagus tumor. And we can switch on to the next slide, which is showing the PET-CT. This is a MIP image showing that there's a hypermetabolic mass in the lower third of the esophagus extending into the GE junction. And if you hit the play button, we'll be able to see axial slices again, showing a hypermetabolic mass in the esophagus that you should see there, and now extending into the proximal aspect of the gastric cardia. Next slide. So this was followed with an endoscopic ultrasound, which showed that it was a T3N0 tumor. Again, it was 7 centimeters in length, extending from 34 to 41 centimeters, and the GE junction was at 39 centimeters. Patient had M0 disease per systemic staging. So the first question here, this is an 84-year-old male with a T3N0 Seward type 1 GE junction adenocarcinoma. What would you recommend for initial treatment? Upfront surgery, preoperative chemoradiation, perioperative systemic therapy with 5-FU, leucovorin, oxaliplatin, docetaxel, which is FLOT, or definitive chemoradiation. Okay. Great, so we're seeing a little bit of mixed response. No one opted for upfront surgery, which is great. And then looks like we're seeing that some folks are recommended preoperative chemoradiation, some perioperative FLOT, and 9% suggested definitive chemoradiation. So we're going to flip to the next slide here, and I'm going to share with you that the thoracic surgery team evaluated this patient, and because of the age and medical comorbidities, they did not think that he was a suitable surgical candidate. So if this patient was planned for definitive chemoradiation, what dose and radiation fractionation scheme would you choose? All right, 95%, 50.4 grade, 28 fractions. Perfect. So we can flip to the next slide. So this is the radiation treatment plan. This is his scan from CT simulation that you're seeing there. So this patient was simulated with an empty stomach for 2 to 3 hours prior to the scan. Patient was positioned in a vac lock with their arms up. We did use IV contrast, and we did obtain a 4-dimensional CAT scan. The volumes that you see, you can go back to the prior slide, please. The volumes that you see on that slide show that the IGTV, which is essentially the gross primary tumor contoured throughout the respiratory cycle, is in red. The high-dose CTV, which is for this patient 50 gray, patient was treated in 50 gray and 25 fractions. The high-dose CTV is essentially the IGTV with a 1 centimeter circumferential margin. And the CTV 4500 includes the gross primary tumor with a 3 to 4 centimeter longitudinal mucosal expansion and a 1 to 1.5 centimeter radial expansion. And then that elective volume also encompassed the gastrohepatic ligament to make sure that the left gastric lymph nodes were encompassed and the celiac lymph nodes. So you see that there, that again, the cyan is the 50 gray volume and the magenta is the 45 gray volume. So this patient was planned with proton therapy, so PTVs weren't generated, but during the optimization process, we robustly optimized such that if there were 5 millimeter isocenter shifts in the X, Y, or Z plane, that the target remained covered. And we encompassed 3% range uncertainty for uncertainties related to proton stopping power calculations. And then you'll also notice that in that region where the esophagus is directly abutting the heart or directly abutting the lungs, that the CTVs were anatomically constrained such that that 1 to 1.5 centimeter radial margin or that 3 to 4 centimeter longitudinal margin did not extend unnecessarily into the heart or lungs. So we can flip to the next slide. This is the plan that you're seeing here. This was a plan generated with proton therapy. We use intensity modulated proton therapy on this case. Most of our cases use posterior oblique beams like you're seeing in this specific case. And on the right, you see a DVH. So the CTV 5000 and GTV 5000 are essentially superimposed. So you just see the single red line that well covered at 50 gray. The magenta is in 45 gray, well covered. Cord max doses in a typical plan, you tend to hope to achieve a max less than around 45 gray, which is quite safe. And you'll see that the max dose on this plan meets that. The heart mean dose on this plan is 7.7 gray. The majority of our proton therapy plans tend to have mean heart doses in the range of 5 to 8 gray. And the lung V20 on this plan is 10%. And you'll see that if you actually look through the dose distribution, I think the most notable benefit with proton therapy is in sparing of the intermediate and low dose volume. So if Juliana, if you could hit the play button again, the isodose lines I want you to pay attention to are the cyan and magenta, which are representative of the distal 20 gray and 5 gray volumes. So there's tremendous sparing of 5 gray from the vast majority of lung and heart, which is really the main benefit of proton therapy in these situations. So we can flip to the next slide. So I very briefly want to go through the care of patients with esophagus cancer. This is a very simplified algorithm, but I think it's quite applicable in the contemporary era. So in patients with clinical T2 to 4 disease or node-positive esophagus adenocarcinomas, the main first differentiator on pathways of care are for those that are operable versus inoperable. If a patient is operable, I think in the post-ESOPEC trial era, the next obvious question becomes, is this patient a candidate for FLOT-based systemic therapy, or do they have medical comorbidities that prohibit that? If a patient is a FLOT candidate, I think the best and most supported regimen, at least at this point in time, is perioperative FLOT. So we would tend to favor giving 4 cycles of FLOT, considering surgical resection at that point, and patients would then get post-operative 4 cycles of FLOT. I think there's an ongoing question as to whether we should front load all of the chemotherapy prior to surgery, perhaps giving all 8 cycles prior to the operation. And there's still an ongoing question if we should add preoperative chemoradiation in addition to FLOT along that type of a pathway. But in general, if a patient is eligible for FLOT, we would favor starting with that approach. If a patient is not suitable for FLOT, then the most evidence-based alternative would be preoperative chemoradiation followed by surgery. And that dose range could be between 41.4 to 50.4 gray in 23 to 28 fractions. And concurrent chemotherapy could either be carboplatin paclitaxel or FOLFOX. and this would be followed with esophagectomy. In those that have a pathologic complete response, they would proceed with surveillance. If there is an incomplete response, 12 months of nivolumab would be recommended. And then on the flip side, if a patient is inoperable, the standard regimen would be definitive chemoradiation, targeting a dose of 50 to 50.4 gray in 25 to 28 fractions. So next, I'd like to talk about some of the supporting literature that provides guidance on that algorithm. The first study and most practice-changing study in this space has been the CROSS trial. This forms standard of care for over a decade. This study included 368 patients with T2 to 3 or N0 to 1 resectable esophagus or GE junction cancers. They could include squamous or adenocarcinomas. 75% had adenocarcinoma. Patients were randomized to upfront surgery versus preoperative chemoradiation, 41.4 gray and 23 fractions with carbotaxol, followed by surgery. And the study demonstrated that there was an improvement in overall survival. Juliana, you can switch the slides for me. The study demonstrated that there was an improvement in overall survival with the addition of preoperative chemoradiation compared with upfront surgery alone. And you're seeing that here with long-term survivors at 5 years in that 40 to 50% range. The study also showed that pathologic complete responses were found in 29% of patients. And when you stratify it by adenos versus squamous, about 50% of patients who had squamous had a path CR, and it's about 25% with adenocarcinoma that had a pathologic complete response. So we can flip to the next slide. So there was a number of studies following CROSS that tried to show improvement in outcomes. Most of them were negative until the Checkmate 577 study. This study looked at patients with esophagus or GE junction cancers, status post chemoradiation, and in those that had an incomplete response, they were randomized to surveillance versus 12 months of nivolumab. And the study demonstrated that there was an improvement in disease-free survival with the addition of nivolumab. And if we flip to the next slide, I can show you that survival curve. So that's shown here with the Nivo group having improvement in median survival, 22 months versus 11 months. So this study was published in 2021. We're still waiting to see the mature data on overall survival from this study. Next slide, please. So now there's the SOPEC study. So this is really what has shifted practice quite substantially since ASCO earlier this year. This study included 438 patients with T2 or node-positive esophagus or GE junction adenocarcinomas, and patients were randomized to perioperative FLOT, which was previously a predominantly gastric cancer regimen. So patients got FLOT for 4 cycles, surgery, and then an additional postoperative 4 cycles of FLOT. And it compared that to the CROSS regimen without the use of maintenance nivolumab. And we can flip to the next slide. The SOPEC study essentially showed that the use of perioperative FLOT offered improved median survival compared with preoperative chemoradiation per CROSS, with a median survival of 66 months versus 37 months and a 3-year overall survival of 57% versus 50.7%. So we can flip to the next slide. So now I'd like to transition to definitive chemoradiation. So the need-to-know study in this space is relatively old at this point. It's 40 years old from its conception almost, RTG 8501, 129 patients, T1 to 3 and 0 to 1, predominantly squamous cell carcinoma. And patients are randomized to radiation alone that was dose escalated, 64 gray, 32 fractions, versus 50 gray and 25 fractions with 5FU and cisplatin. And if we flip to the next slide, you'll see that the combination chemoradiation arm offered improved overall survival compared with radiation alone. And I think what's most striking is that radiation alone, even at 64 gray, there were 0 survivors at 36 years, essentially suggesting that the really only way to definitively cure patients in the absence of surgery is combination chemotherapy and radiation treatment. On the next slide, what I would also like to highlight is despite chemoradiation being better than radiation alone, the figure on the left is showing proportion of patients with local recurrence. And you'll see that with chemoradiation, we still have about a 40 to 50% risk of local regional recurrence, despite that therapy at 50 gray. So it leads to this obvious question of, is 50 gray sufficient radiation dose? So I'm going to flip to the next slide. There are at least 5 randomized studies presented to date that have evaluated this question. This is the Art Deco trial. This study included 260 patients, T2 to 4 and 0 to 3 cancers. They included both adenos and squames. About 62% were squames. And patients are randomized to 50.4 gray, 28 fractions with carbotaxol versus a simultaneously integrated boost to 61.6 gray targeting the gross primary tumor. And on the next slide, you'll see that there was no improvement in overall survival or progression-free survival with dose intensification on this study, nor was there an improvement on any of the 4 prior trials that looked at this specific question. So again, visiting our algorithm again, those studies that I just shared essentially form the backbone of why I think this is a pretty reasonable, simplified algorithm for the care of these patients. Again, with that first decision point being if they're operable versus not. If they are operable and FLOT candidates, starting with FLOT would be most appropriate. If they're not FLOT candidates, preoperative chemoradiation would be a suitable alternative. And if patients are inoperable, standard regimen would be 50 to 50.4 gray in 25 to 28 fractions with either concurrent carbotaxol or FOLFOX being the most common strategies. So at that, I'd be happy to take any questions. And Nina, of course, if you have any comments, I'd love to hear your perspective too.
Thank you very much, Dr. Jethwa. We have some questions in the chat. Do you contour or constrain any cardiac substructures?
Yeah, that's a good question. We don't routinely do that in our practice. The vast majority of our patients with esophagus cancer now are treated with proton therapy. And so inevitably with that beam design, there's going to be high LET end of range in the posterior aspect of the heart. So that may be one thing to consider. But in the absence of that, doses to other cardiac substructures like the LAD and valves are very low. So we don't particularly do that with proton planning.
Thank you. And another, if the patient is found to be inoperable due to deconditioning after FLOT, what would your regimen be for chemo RT?
Yeah, I would do 50 to 50.4 gray in 25 to 28 fractions with concurrent chemotherapy. And if they were deconditioned on FLOT, but on interval imaging at least demonstrated response to it, my preference would be FOLFOX-based chemoradiation. If there was relatively poor response on FLOT, I would be very comfortable transitioning to carbotaxol, which would be a likely more tolerable regimen.
Thank you. And another question, why did ESOPEC exclude SCC?
Yeah, that's a good question. So the study that established FLOT as the standard in gastric cancer included only adenocarcinoma. No patients with squamous cell carcinoma were included on that study. And that's the FLOT4 trial. It did include patients with GE junction and gastric cancers. And so that really formed the backbone historical data to support the use of FLOT4 in the ESOPEC study. And because it's prior use in only adenocarcinoma, I think it makes most sense that it was applied to adenocarcinoma in the ESOPEC trial. Now that being said, we do also know that combinations of 5-FU-platin and taxanes are effective regimens in squamous cell carcinoma also. So there has more recently been a JCOG study that looked at that type of approach, docetaxel cisplatin 5-FU compared with preoperative chemoradiation for esophagus squames. So we do have both sets of data at this point to guide us on those outcomes.
Thank you. Another question, do you do assessment for surgery omission, i.e. the SANO trial?
Yeah, that's a good question. So the SANO trial has not been published yet. It's not a randomized study per se. They randomized by centers essentially. And there's a pretty strong suggestion from that study that there's a fair proportion of squamous cell carcinoma in the study. It wasn't purely adenocarcinoma. So at least at present, I think for operable patients, the current quote unquote standard highest level evidence would suggest that the addition of surgery is meaningful. But frankly, what we do not know based upon a randomized phase 3 trial is if you have a patient with adenocarcinoma that has complete response to treatment, can they safely omit surgery with a non-inferior outcome? I think that's a question and a trial design that a lot of us would love to see, but we don't have definite guidance from a clinical trial, at least at present. So in our practice, if a patient's open and interested in surgery, that's the route that we tend to favor. If a patient is more averse to an operation, then we are quite comfortable in doing a response assessment and active surveillance as long as they're open to it. And the pre-Sano study provided guidance on the optimal assessment metrics for esophagus cancer. It should include CT, chest, ab, and pelvis for systemic staging, PET CT also for systemic staging, but we know that PET CT is not great at definitively guiding management of the primary tumor. So it should also include endoscopy with a deep biopsy, which they describe as bite on bite, which essentially means they want to assess the mucosa and submucosa or muscularis with the biopsy. And with that metric, they can be pretty good at identifying complete responders. For
Yeah.
squamous, it's the opposite. Oh, go ahead, Nina.
Oh, I was just gonna say, yeah, I totally agree with you. I think for, for esophagus, for pre-op, you tend to do a PET 4 to 6 weeks after completing chemorads. And as we know from other GI sites, that's not really enough time to see a response. It's going to keep responding after that. So cases where we may be a little bit more inclined to think about definitive chemoradiation and so-called watch and wait would be squamous cell cancers, where if, on that initial PET, they have a really good response, it's almost gone, then in those cases, we might push back a little bit, given that we know that these cancers are more radiosensitive. And I think it really also depends on the surgeons, how willing they are to consider salvage surgery. And our surgeons feel that, if a patient has a near complete response, a complete response, then you're not really worsening their outcomes by potentially delaying surgery. I will say that again, the Sano trial is not published, but I think the follow-up results were presented at some meeting, and someone posted some like ominous message that like the surveillance arm had worse distant meds, but like without any more data than that. So we really have to see the results of those studies to know what we make of it.
Yeah, I share the same thoughts as Nina, and I'd like to also add that at least for squamous cell carcinoma, we already have 2 randomized studies at least that looked at patients with squams that were operable candidates. They got chemoradiation and were randomized to receive observation after that versus surgery, and surgery did not improve overall survival. So we already have data in a relatively unselected group, meaning complete response was not mandated in those trials, that omission of surgery is a suitable strategy.
Thank you. We have one more question before we wrap up our session. Would you consider dose escalation for cervical esophagus treatment?
So early in my practice, I was a head and neck and GI rad onc, and now I'm more differentiated to just GI. I would say 5 years ago, I was treating a lot of these patients to a higher dose in the range of 54 to 60 gray. More contemporarily, I tend to stick with around 50 gray. The rationale for that is that if you look at the management, of course, you can draw in head and neck principles as well, but the only prospective trial was just a phase 2 single arm study for cervical esophagus cancer. They treated to a dose of 60 gray with concurrent single agent cisplatin typically. Some of the studies have used cisplatin 5-FU, but a lot use single agent cisplatin. Whereas if you look at esophagus cancer management, we're using chemo doublets of cisplatin 5-FU or Folfox or carbotaxol. And we have at least 5 trials that show no benefit to doses beyond 50 gray. So in general, I treat to 50 gray with a chemo doublet, but I'd also be perfectly comfortable going to 54 to 60 gray if it's a small disease burden in a patient who wanted to be more aggressive. But Nina, what's your approach?
Yeah, so I was clarifying my comment in the chat, but if it's a squamous cervical, then a lot of those do go to our head and neck team, and I know they dose escalate. But otherwise, yeah, I completely agree. I mean, it's hard not to, because you're like, I just want to give it more dose. But when you have multiple randomized trials that are negative, then you can't say you like believe randomized data and then not believe when the dose escalation studies are negative. So I will sometimes go to 54, but I really don't think we have data to go above that.
Thank you. Thank you so much, Dr. Jethwa, for the excellent presentation. And I apologize we haven't gotten to everyone's questions, but it's now time to wrap up our session. And thank you to all our presenters, Dr. Sanford, Dr. Buckstein, Dr. Jethwa. Just before we end, I'd like to mention that we're doing additional ROVER sessions. Our next one is in February. It's on GU malignancies. And then we also have one on lymphoma and heme malignancies that will be in April. So please sign up on the ROVER website. We'd love to see you all there. And finally, thank you very much to our presenters. All attendees will receive an email, and we'd love for you to fill out our post-session survey. Your feedback is important to us.
Great.
Thanks,
Thanks,
everyone.
everybody. Bye.